Good afternoon, everyone. My name is Anne Wong with the Illinois Chapter, American Academy of Pediatrics, and I thank you for joining us for today's webinar, You Are the Key to HPV Cancer Prevention. Today we are joined by Jill Rourke from the Centers for Disease Control and Prevention. Before we begin, I would like to go over a few housekeeping items. Participant phone lines are muted throughout the webinar.
No, so she didn't do that. And it was two security people come down, and they don't look like.
Sorry about that. Okay, if you have any questions for our speakers during the presentation, please enter them into the question box on your control panel for the webinar on the right-hand side of your screen, and Jill will answer them at the end of the presentation. Mrs. Jill B. Rourke, MPH, began her career in public health in 1997 as a pediatric diabetes educator. Jill then worked in the clinic at Planned Parenthood of North Central Florida, where she provided case management for abnormal Pap follow-up and managed the colposcopy clinic. Jill then moved to Georgia, where she began working at the Emory University School of Medicine, first with a federal-level training program for public health clinicians, and then at the Emory Vaccine Center coordinating immunization research activities for HIV vaccine clinical trials. Jill began working at the CDC in 2004, providing communication, consultation, and project management, first in the CDC Office of the Director and then for the National Center for Health Marketing. Currently, Jill leads the Adolescent Immunization Communication Team in the CDC's National Center for Immunization and Respiratory Diseases, focusing on HPV vaccine communication science for parents and clinicians. Please join me in welcoming Jill Rourke.
Can you hear me okay? Hello there. Hi, Anne. Can you hear me okay? I'm going to take that as a yes because I can actually see that it's picking me up. All right, so I'm going to go ahead and get started because we have a lot of slides today. So the things that I'm going to go over include talking about why HPV vaccination is so important for cancer prevention and why it is that we vaccinate at ages 11 or 12. We're going to talk about what the specific ACIP recommendations, and these are also the AAP recommendations for HPV vaccine for girls and boys. And then also I'm going to give you some information that you can use in talking to parents in order to help them make the decision to vaccinate. And then of course we'll provide you with some resources that are relevant to your current immunization practice. So first we're going to start with understanding the burden of HPV infection and disease. So almost everyone is going to have at least one type of mucosal or genital or oropharyngeal HPV at some point in their life. And there's a lot of infections, nearly 80 million with about 14 million new infections every year. Most people are infected soon after the very first time they have sexual intercourse, which is why we see that HPV is more common in teens and young adults in their early 20s. But as you know, most people have no idea they've been infected unless they have visible genital warts or it's a female who's been told she's HPV positive or has some type of cervical anomalies. Most folks just go on and never have any idea that they've been infected. But every year in the United States, persistent HPV infection causes 27,000 people to be diagnosed with a cancer caused by HPV. And if we break that down, that is one case every 20 minutes. 27,000 doesn't seem like very much until we think about it in terms of time. Here's one way that we can look at the number of cases between women and men. You can see that nearly twice as many HPV cases occur in women, the majority of those occurring in the cervix. In men, we have nearly 10,000 cases a year, with the majority of those occurring in the oropharynx. And we define that very narrowly. The oropharynx is the back of the throat, base of the tongue, and base of the tonsils. It's a very difficult area actually to determine if there's any precancerous lesions in. So we actually don't have a precancerous state for oropharyngeal cancer, which makes it really difficult to detect. And so there's no early detection or screening program for that. There is some promising HPV virus detection or infection detection technology on the horizon, but it's not available yet. All right, so if we look at just women very specifically, if we didn't vaccinate anyone, the annual burden of HPV disease in women would cost us about $7 billion a year, in total about 3 million cases. And so that's all the way from genital warts to low-grade cervical dysplasia, high-grade cervical dysplasia, cervical cancer cases, and cervical cancer deaths. And so often we only focus on the very tip of that pyramid, which is the cases of cervical cancer and the cervical cancer deaths. What I want to highlight is actually the next section down, which is high-grade cervical dysplasia. So we have about 330,000 new cases every year of high-grade cervical dysplasia. And that means that these women have gone in, they've been told they have an abnormal PAP, and they're going to have a colposcopy. And so during that colposcopy, they're almost always going to have biopsies taken, and then they possibly will have additional treatment done, whether that's a looped electrical excision procedure, or even possibly a cone biopsy. And both of those things can cause complications later on, possibly maintaining a pregnancy because of the cervical instability, which then can cause problems with preterm labor and preterm birth. Obviously, the million new cases of genital warts each year causes a lot of emotional distress to the people that get them. So we don't want to discount that either. Okay, I'm going to talk a little bit more about cervical cancer, since that is the main burden of the disease that the vaccine was originally indicated for. And so it is the most common HPV-associated cancer among women. And in the United States, prior to having a good early detection program through the PAP test program, it was the deadliest of all of the female cancers. And we've been able to decrease those numbers so tremendously with using excellent screening and treatment. But still, with screening and treatment, we still have over 10,000 cases a year. Worldwide, it's about 500,000 cases or more, and about 275,000 deaths because of those cases. So you can see that across the world, because of not having an early detection program in place, or a very strong one, it's not having as much of an effect. So definitely HPV vaccine has the potential to make a huge impact in our country and around the world. And there's one other thing that I want to point out, because sometimes people think of cervical cancer as being an older woman's disease, but it's really important to note that 1/3 of the cervical cancers that occur are happening to women that are between the ages of 20 and 44. And if we break that down, you can see that 1 in 8 of those cancers are happening between the ages of 20 and 34, and 1/4 of them are happening between the ages of 35 and 44. And especially with professional women who are delaying childbirth, if they have cervical cancer and have to be treated with a hysterectomy, they may never be able to have children if they have not started their families yet. So while all types of HPV cancers are on the rise, some are disproportionately affecting different racial and ethnic minorities. Unfortunately, as I said before, there's no routine screening for specifically oropharyngeal cancer or anal cancer, vulvar and vaginal cancer, or penile cancer. And so for these cancers, not only is vaccination our best strategy, it's our only prevention strategy that actually works. Abstinence is not necessarily a good strategy for adults, and so we can't expect that. It is an acceptable strategy for young people, very young people, teenagers, but it's just something to think about, that this is HPV vaccine is what we're going to use to prevent many of these cancers. I do really want to point out that how much increase we're seeing in oral cancer, oropharyngeal cancer specifically. In the next couple of years, we actually expect the number of cases of oropharyngeal cancer caused by HPV infection, so not the ones caused by alcohol and tobacco use, but specifically the HPV positive oropharyngeal cancers, to eclipse cervical cancer in women. And specifically that's men and women oropharyngeal cancer cases. All right, so now I'm going to focus very specifically on HPV vaccine. So the HPV virus-like particle is pretty amazing in terms of how it's created and engineered. It's just one piece of the virus that is then duplicated over and over to make a shell, which you can see on the screen. It's phenomenal. It has no internal parts, so obviously that makes it non-infectious and non-oncogenic. What's amazing about this HPV virus-like particle is that it actually produces higher levels of neutralizing antibody than if someone was naturally infected with the virus. All right, so I'm sure you know that there's we now have 3 vaccines in the market, 2 different manufacturers. And so I have here on the slide, at the request of many physicians over the years, just a breakdown of what that looks like. And so bivalent vaccine is still used. While it's not used a lot, we have about 1 million doses of bivalent vaccine has been distributed in our country. We've had close to 79 million doses distributed of quadrivalent vaccine, which is Gardasil, and no numbers yet on 9-valent, but we just started using that as it was just recommended by the ACIP in February. For things I want to point out here are around the contraindications. So the hypersensitivity to latex in the prefilled syringes of the bivalent HPV vaccine and hypersensitivity to yeast in both the quadrivalent and 9-valent HPV vaccine, those are anaphylaxis levels. So the contraindication is if someone has an anaphylaxis level reaction to those materials. And as you can see, the dosing schedule is a little bit different for bivalent from quadrivalent and 9-valent, but the ACIP harmonized those in the recommendation. Now we can look at the different types of HPV or HPV types that are included in the vaccine. So you can see with bivalent, we have there 16 and 18, quadrivalent 16 and 18. 16 is the type that causes the most cervical disease. 18 follows shortly behind that. 6 and 11 is what causes genital warts. And so you can see that bivalent vaccine was originally is just indicated for women for protection against cervical cancer and precancerous lesions. Quadrivalent vaccine indicated for both men and women because it also provides protection against genital warts, 6 and 11. Merck also has an indication for anal cancer, which is 90% of anal cancers are caused by HPV, most of those HPV 16. The 9-valent has 5 additional types in it that are going to prevent somewhere between about 10 to 15% of additional cervical cancer. And so we are really boosting the amount of cervical cancer prevention that we're able to achieve using 9-valent HPV vaccine. All right, so let's talk about the HPV vaccine recommendation. Both girls and boys can start as early as age 9, and that is the harmonized ACIP recommendation. We want all preteens to have finished the series by the time they turn 13. Girls who haven't started or finished the HPV vaccine series should also be vaccinated, as well as boys. Boys, we only go up to age 21, girls up to age 26. Now, one other thing here is that if for males, and this isn't necessarily your patient population, but males who are 22 to 26 who are immunosuppressed with either HIV or asplenia should also be vaccinated, as well as any young men who identify as having sex with other men. So there is your caveat to the boy recommendation. All right, so this is just one more way to look at this. Again, we routinely recommend HPV vaccine at ages 11 or 12, and that's the full series. Start it and finish it during the 11 to 12-year-old span. Through 26 for females, through 21 for males. And then additionally through males age 26 who have these other, whether men who have sex with men or they're immunocompromised. And then if you look at the formulation by gender, you can see that males can get either of the Gardasil products, but they cannot get the Cervarix product. It was not indicated for them. And it was also not studied in the clinical trials in men for Cervarix. All right, so in terms of interchangeability, this is a question that we get all the time, and especially now that we have a third product on the market, we hear a lot. So if a vaccine provider doesn't know or doesn't have available the vaccine product that was previously administered, or if they're in a setting that's transitioning or has transitioned to 9-valent HPV vaccine, females can be given any HPV vaccine product to complete the series. Males can be given either quadrivalent or 9-valent. Now, what's really interesting about those 5 additional types of HPV is that they're going to produce the most benefit in young women because it's related to cervical cancer, and there isn't a ton of benefit for young men. So if you're a practice that's transitioning to 9-valent vaccine, or you have transitioned but you still have some quadrivalent vaccine in stock, you can give that to your male patients and then save the 9-valent for females. But pretty soon I would think that most offices will have completely transitioned and not have any regular Gardasil or quadrivalent vaccine left over. Okay, so in terms of the timing, again, we have 0, 2, and 6 months, and they're all administered on the same schedule. The interval between doses 1 and 2, we can say about 6 weeks or 1 to 2 months, and the interval between doses 1 and 3 is 6 months. So an easy way to tell parents this is you need to come back in about 6 weeks and then again in about 6 months. If the vaccine schedule is interrupted, it does not need to be restarted. So we hear this all the time, especially from young people saying, you know, I had my first shot while I was in high school and now I'm in college and I haven't finished it yet. Do I need to restart the series? No, they don't need to be restarted. Whenever they come back in, they can go ahead and get that second shot, third shot. And interestingly, if someone has started the HPV vaccine series before they turn age 27, insurance still has to pay for them to complete the series. And so that's actually part of the ACIP recommendation, is that anyone who started the series before turning age 27 should finish the series. And so that caveat within the recommendation is what provides for insurance to provide coverage for that. All right, so 3 things that are good to know about HPV vaccine. 1, it's safe. 2, it works, and 3, it lasts. From all the data we have, we can see that HPV vaccine protection is very long-lasting. We're not seeing any evidence of waning protection. This is very different than what we've seen with some of the other adolescent vaccines. Meningococcal, we now have a second dose, and you know, one of the Tdap vaccine with acellular pertussis, we're not seeing the duration of protection as long as we did when it was a whole cell pertussis vaccine. In terms of how well the vaccine is working, we are already seeing tremendous population impact against both the early outcomes, which is knowing prevalence of infection, as well as mid outcomes, prevalence of genital warts. We've seen this in our country and other countries. And of course, HPV vaccine is safe. You know, besides the MMR vaccine, we've probably looked at HPV vaccine more than any other vaccine. And the Immunization Safety Office and many different researchers around the country are constantly looking very closely at HPV vaccination. So when we say that HPV vaccine is safe, there's a lot of confidence in that statement. The benefits of vaccination far outweigh any potential risks. I know there was an article that came out recently talking about anaphylaxis, and anaphylaxis is a concern if someone has an allergy to yeast or latex that is a hypersensitivity at the level of anaphylaxis. So they should not receive that vaccine. They should get one or the other one. So if it's yeast, they want the one, they want the other vaccine. Safety studies really for HPV vaccination are about the same in terms of meningococcal conjugate vaccine and Tdap vaccination. So really seeing the same type of safety findings for all of those. So they're all equally safe. All right, so I'm going to go into HPV vaccine safety a little bit more in detail. So this is just an image, and this is something that you can actually download from CDC. It's part of a much bigger infographic, but it seems to be the thing that parents ask about the most. And so the infographic is the journey of your child's vaccine, and it shows how vaccine safety continues to be monitored after a vaccine has actually been recommended as being used widely. And so it talks about the type of monitoring that is done, the different systems, and then what happens. And I think that something that's really important to tell parents is if any safety concerns are detected about these vaccines, the vaccine recommendation may change based on that. And I'm sure that many of you, if you've been in practice for a while, remember that with the original rotavirus vaccine. So we saw safety concerns, it was removed from the market. There's a new rotavirus vaccine that's safer. So in terms of monitoring, just some important things to remember. Most reports to VAERS are actually considered non-serious. And then if you think about what the serious reports are, so not even 8% of the reports are coded as serious, but serious includes things like headache, nausea, vomiting, fever, fainting. And so not all of those 7% of serious reports are necessarily what a provider would consider serious. It might be considered that by parents. In terms of syncope, it is the reason why we do continue to recommend a 15-minute observation period after vaccination. And this isn't just for HPV vaccine. This is for any shot or medical procedure that a preteen is going to have. They have a very immature vasovagal system, and they are prone to falling out. And it might have something to do with the amount of drama that occurs during the preteen years. That's just my opinion. All right, so in terms of findings from the various safety studies, we've seen no increased risk of venothromboembolism following quadrivalent vaccine, and that's been studied over several years. In terms of autoimmune condition, again, no association between a quadrivalent vaccine in 16 different autoimmune and neurologic diseases. And most of these, by the way, the reason why these are all about quadrivalent vaccine is, again, that is nearly 80 million doses distributed are quadrivalent, only 1 million bivalent, so the safety studies focus on the one that's been distributed the most. And again, in terms of injection site reactions and syncope, no major safety concerns found. But again, with syncope, this is why we recommend that someone receive their vaccine sitting down and then be monitored, especially when they go to stand up, because that actually is when it usually occurs. Even after 15 minutes, that can occur. All right, so again, I mean, this is sort of a repetition of what I've already said, but when the IOM, Institute of Medicine, did their review, they looked at 8 different vaccines and then various adverse health events. No surprise here at all. There was it favored acceptance of a causal relationship between HPV vaccine and anaphylaxis when the person was allergic to the item in the vaccine, whether it be yeast or latex. And then the evidence convincingly supported a causal relationship between the injection of any vaccine and syncope, so things that we already knew and expected. They looked at 12 specific health events and did not find any evidence to link it with HPV vaccination. All right, so in terms of 9-valent HPV vaccine, which is what most people are going to be using, there were 7 pre-licensure studies, including 15,000 young men and women. It was generally very well tolerated, and the adverse event profile was very similar to quadrivalent vaccine, especially across age, gender, race, and ethnicity. However, it is important to note that there were more injection site reactions seen and expected among those who received 9-valent vaccine. So just something to notice, more redness, more sore arms, more swelling. All right, so now I'm going to talk a little bit about HPV vaccination impact. When I talked earlier about the early outcomes versus mid outcomes versus late outcomes, I want to define those for you. So because cervical cancer takes so long to develop after someone has been infected, we won't probably see a change in our cervical cancer rates or other HPV-associated cancer rates for decades. Whereas it will only take years to maybe a decade for the mid outcomes, which is our low and high grade dysplasia or precancers. In terms of our early outcomes, it hardly took any time at all for us to see a decrease in HPV prevalence. In fact, data was published a couple years ago that in just the first 4 years after the HPV vaccine program started in the United States, we saw a reduction in the group that was most likely to have been vaccinated by about 56%. And then also tons and tons of genital warts. Studies are going on and seeing dramatic decreases in genital warts across the country and in other countries as well. And so that's actually what I want to talk about here is that in Australia, New Zealand, Denmark, Sweden, Germany, Quebec, definitely seeing a decrease in genital warts as well as HPV prevalence. Australia has incredibly impressive data about cervical lesions decreasing in the population that's been vaccinated, or that age group. They got to 80% of their young female population vaccinated very quickly, so they've been able to see outcomes sooner than we originally expected. So this is what I mentioned before, that in 14 to 19-year-olds we saw more than 56% decrease within 4 years after the vaccination program began. We didn't see that in other age groups, which isn't surprising because the majority of those vaccinated were between 14 and 19. Very few college-age girls were actually getting vaccinated in the first few years. Vaccine effectiveness for the prevention of an infection was estimated to be about 82%. In countries with high coverage, we actually see tremendous impact. So prevalence decreasing, genital warts decreasing, some evidence of herd effects. Probably one of the best that we've seen is actually in Australia, where they did not vaccinate boys until 2012, and yet the prevalence of genital warts in young men decreased tremendously as girls were vaccinated. So within just a few years, the vaccination program beginning, they were already able to see tremendous decrease in prevalence of genital warts in young men, and they weren't being vaccinated. So we're definitely seeing evidence of herd effects. There's also some evidence of cross-protection against the other types, and that's kind of interesting too. A lot of folks were originally worried about type replacement. So if we prevent 16 and 18, we see others become more prevalent, but actually what they're starting to see is that other types are being prevented as well. So more to come in data as we learn more about that. All right, and I mentioned before, duration of immunity. Again, studies are suggesting that vaccine protection is quite long-lasting. We're not seeing any evidence of waning immunity at all. There's lots of studies in progress to measure this. Because the vaccine is coming up on its 10-year anniversary, which is amazing, we only have about 10 years of data on vaccine protection. And so in terms of being able to look at that data, we can say that we know for 10 years this vaccine works incredibly well. But because it's not waning quickly, we don't expect there to be some big drop-off that will occur anytime soon. So you can have confidence that when you're vaccinating an 11-year-old, they're going to be protected well into college. And as the years pass, we'll have more and more data on that as well. Right, so now I'm going to talk about, we have this great vaccine. It works really well. It's safe. It's incredibly effective. We've seen huge impact, and we're just not seeing great coverage. And so I want to talk about that a little bit. And here on the slide, we actually have a comparison between the United States, United Kingdom, and Australia. All right, so looking at coverage, and this includes the most recent coverage data that was published at the end of July on July 31st from the National Immunization Survey Teen. And this goes all the way back to when we first started collecting data in 2006 when the vaccines were first recommended. And I think what's really important to point out here, so if you see the green line, that's one dose or series initiation for girls, and the purple line is series completion for girls. And they're pretty low, and you can see they really started to separate from the pack between 2009 and 2010. But we continue to see high rates of vaccination in teens, 13 to 17, with both Tdap and meningococcal conjugate vaccine. And so what that tells us is, in our current healthcare structure, we can get preteens and teens vaccinated. They are coming in and getting vaccines. They're just not necessarily getting HPV vaccine. And so, oh, and by the way, these lines change from dotted to solid because we actually changed the definitions this year around provider verification. And so it changed the numbers just a tiny bit. All right, so as I was saying before, when a preteen gets a vaccine but not HPV vaccine, we call that a missed opportunity to provide HPV vaccine. We know that many girls have had missed opportunities, and where we are versus where we could be, the difference is quite big. And there's a lot of reasons for missed opportunities. I mean, it could be that mom comes in and says, nope, I only want the vaccines that are required for school. And I know many of you probably hear that. All right, so If we look at just girls in Chicago, you can see very specifically that we could be achieving up to 98% coverage, which is pretty amazing. And just to give you an idea, and this is actually last year's data because I haven't gotten this for this year's data yet, but you can just kind of see where Illinois falls. Don't be tormented by Rhode Island. They only have about 100 teens, and so, you know, we'll leave them off to the side. They're fighting their own battle right now in terms of their school mandate. All right, so now I'm going to shift the conversation, quite literally. We're going to talking about HPV vaccine, where we really feel like we can influence the HPV vaccine decision-making process. Happens in three very specific places, or there's three specific levers, and that is doing what I'm doing right now, talking to clinicians like yourself, sharing information and motivating parents to have their children vaccinated, and then the actual conversation that occurs during the visit. All right, so this is a small study that was done in Texas and that we're actually looking to replicate here soon with some CDC data. Oops, and I went too far. All right, so how parents feel about HPV vaccines. So parents were asked to rate these vaccines on a 1 to 10 scale, and you can see that across the board, whether it was meninge, hepatitis, pertussis, flu, HPV, they ranked them all about the same, all above 9. And then providers were asked to estimate how much they think parents value these same vaccines. And I'm sorry, my slides keep going kind of crazy here. And when we talked about meningitis, hepatitis, and pertussis, you can see that they are guessing it's about the same. So they're perceiving parents value these vaccines. But when providers were asked about flu and HPV and adolescent vaccines in general, there was actually a big difference. And so providers aren't perceiving that parents value these vaccines. And I don't know why this keeps happening, but I apologize for this. So essentially, you know, the hesitancy that parents have had around childhood immunizations, it would seem that those same parents are going to be very hesitant about HPV vaccine. What's different about HPV vaccine is it seems like when actually just looking for more information and reassurance from the physician. And so that's a little bit different than what we're used to. So one of the things you can do is use those questions as an opportunity to reinforce their decision to prevent cancer in their child by getting them vaccinated. You know, a strong recommendation from you really is the main reason why parents vaccinate, and many parents say that they trust their child's physician and would get the vaccine as long as it is recommended. So we talk about strong recommendations and effective recommendations, but really the best thing I can say here is when there is an 11 or 12-year-old in the exam room, a great way to start the vaccine discussion is to say your preteen needs 3 vaccines today. They're going to give them protection from meningitis, cancers caused by HPV, as well as a booster for pertussis. Giving that bundled recommendation actually really helps parents see them all on the same level playing field. So even if a vaccine isn't recommended for school, that doesn't mean it's not important and isn't recommended. When parents hear the clinician talk about just Tdap and meninge as the required vaccines, and then we also have HPV vaccine, it sort of sets it up like they're not on the same playing field. And so that can actually kind of deter a parent from being as confident in choosing HPV vaccine for their child. Something else that's really important is when parents start to have questions about HPV vaccine to focus the conversation on cancer prevention. That seems to be what helps parents make the decision to vaccinate. Very specifically in our research with parents, they've told us they don't want to talk about sexual transmission or talk about the vaccine in the context of sexuality. The one other thing we recommend during the conversation is to address parents' questions directly. So just answer the specific question that they're asking. So if it's why it's at 11 or 12, or you know, would you get this for your child? And we're going to go through some of those in a moment. So that was sort of my intro, and now I'm going to go through these one at a time. So what we consider an effective recommendation to be is one that groups all of the adolescent vaccines. So you recommend HPV vaccine the same way you're recommending Tdap and meningococcal vaccines at the same time. In fact, we go as far as to say that HPV vaccine should actually be mentioned in the middle, sandwiched between meninge and Tdap, especially because Tdap is such an accepted vaccine and saying it last seems to help parents. And then also recommending them on the same day. So when using the prompt of a preteen coming in during back to school season and saying, I got to get these vaccines so I can start school, saying, yes, you do need 3 vaccines. They're going to protect you from meningitis, HPV cancers, as well as pertussis. All right, and then you've probably seen this before. This is probably not surprising to you, but if you have parents that are hesitant, we want to ask, acknowledge, advise, and then remember. So make sure that you understand exactly the question that parents are asking. And then we do want to acknowledge that it's their decision, but we also want to acknowledge the risks and benefits and what the conflicting information sources are. I heard a great talk from a doctor who said that when a parent says, well, I read some stuff on the internet and it really scared me, and the provider said, I want you to either bring that in and I'll go over it with you, or email me and we'll set up a time to talk by phone. And the provider would actually go through and show them why that maybe wasn't a credible piece of information, and then how to get credible information about HPV vaccine safety. And then also advising, so being very specific about pros and cons and things like that. We do have the tips and time savers sheet that I'm sure many of you have seen, and I'll show it later on. That can be a really helpful way to address parents' questions about HPV vaccine. And then also the remember part. We know that it's not final. When if a parent says no, it can be revisited. We want to make sure that we're deciding on an action that we agree with. So we're going to talk about this when you come in next year or when you come in for your flu shot. As I said before, some parents just need reassurance. There's going to be a lot of parents who just say yes to the bundled recommendation. That seems to be a very successful way to recommend HPV vaccine, but some parents will have questions. And so we don't want you to interpret a question as delay or refusal, but instead as looking for additional reassurance from you, the clinician that they are trusting with their child's health care. And so again, going back to make sure you're addressing their actual concern. So this is what the effective HPV recommendation sounds like. Your child is due for 3 vaccines today. Sophia, we'll use her name. Sophia is due for 3 vaccines to protect her from meningitis, HPV cancers, and pertussis. We'll give those shots today at the end of the visit. And there's been some research showing that use of today really helps reinforce in parents that you want their child to be vaccinated right then. If parents ask you, well, I don't understand, why would my child need this vaccine? I know why they need the ones for school, but why do they need this? And we want to emphasize that it's important for cancer prevention. And then also go on to say, I know we both want to protect Maureen from any type of cancer, and we can with this vaccine. So I'd feel better if your daughter got the first dose of HPV vaccine today. We have a lot of parents that that ask this question. We know because we have a lot of providers that tell us about it, and that is, you know, we have family values that are such, or you know, we're a very religious family, or I just, you know, my daughter's not into this yet, whatever it be, or my son's not into it, he's still playing PlayStation, you know, for 4 hours a day. Well, FYI, my husband is certainly out of range to get HPV vaccine, and he plays his games for hours a day. So, but if someone says to you, you know, my child won't be exposed, we want to remind them that HPV is a very common virus. Almost everyone's going to be exposed, and that when a daughter marries, she could be getting it from her husband because he may be infected before he ever meets her. So around that same thing, a why now, let's wait until older, we also want to let parents know that the data shows that HPV vaccine is producing a very robust immune response in preteens, which is why we recommend starting the vaccine series now. There are parents that are still asking if they're just giving their child permission to have sex by giving them HPV vaccine. There's a set of videos out of Minnesota that are really funny where a physician says, a mom asked that question about Tdap vaccine and running on rusty nails to kind of show that, you know, really this isn't even frankly on kids' minds. If you give them the vaccine at 11 or 12, most of them don't even make the connection. And plus, studies have shown that even for teens that have received the vaccine, they are not more likely to have sex or have sex at a younger age. And we have lots of data on that. You may get asked if you would give it to your child. In addition to answering that question and saying, yes, I did give this to my child, cancer prevention is really important to me, I wanted to make sure they're protected well in advance. You can also just offer this information if a parent is hemming and hawing and say, I really believe in this, I've given it to my own child, or if you don't have children or your children are grown, a grandchild, someone else in the practice's child, but someone you know. Okay, now the biggie, of course. So some parents are still very concerned about vaccine safety, and it isn't just HPV vaccine. And so if they ask about side effects, we can tell them that vaccines, like any medicine, can cause side effects. But what we know from the data is that most of the side effects with HPV vaccine are mild, pretty much just pain or redness in the arm, and that goes away quickly. The vaccine hasn't been linked with any serious or long-term side effects. Now, we do get some really specific questions around side effects and HPV vaccine safety, and one of them is around possible effects on fertility. And so you can tell a parent that asks specifically about, well, I've heard that it could cause some problems with fertility. You can say there's no data to suggest that HPV vaccine has any effect on future fertility. In fact, there are many women that actually were vaccinated while they were pregnant, and women that were vaccinated prior to being pregnant and went on to have children because the vaccine was tested up to age 49. But we do know that persistent HPV infection can cause cervical cancer, and that the treatment of that cervical cancer can leave women unable to have children. Sure, there are fertility preserving methods, but those are expensive and not done very often. And we also remind it it's not just cervical cancer. You know, the treatment for cervical precancer, as I mentioned before, can put a woman at risk with cervical instability, causing preterm delivery or other problems. So one thing we don't want to forget to do is to remind parents that they need to come back. So after that first dose, your child is going to need all 3 shots, and so you're going to have to come back in 6 weeks and then again in 6 months. Make sure that you put these appointments on the calendar before you leave the office today. Now, in order for a parent to do that, you have to have a scheduling system that's able to make those appointments 6 months in advance. And that really seems to be helping parents, even if they have to change the appointment. Having that prompt on the calendar for 6 months from now helps them get the kids back in to complete the series. All right, so let's talk about how it is that we can increase the number of your 11 and 12-year-old patients who come in and then leave vaccinated. So working with your entire office, you can align the office policy with your mission to immunize at every opportunity. You can align your communication with that mission as well. One way that you can also do this is through standing orders, and especially this is helpful for completion of the series. If your office doesn't want to use standing orders, you can also have something in place to remind the person who is supposed to order the vaccine. But standing orders can be helpful if someone wants to come in for a nurse-only appointment to get the 2nd and 3rd doses. They've already been in for the 1st, and now, you know, it's not a matter of needing to convince them to be vaccinated, but just finishing out the series. Also, prompting the person who's supposed to order the vaccine, whether that's the nursing personnel that does that for you by stating it on a sheet, or the electronic health or medical record to give you a pop-up message. It is good to combine an EHR prompt with some other form of nagging, and so we actually recommend, even if you have the prompts set up, do encourage to have the staff that orders the vaccines to, whether it's circle all the patients that need the vaccine, or when the medical assistant or nurse is leaving the exam room after taking the vitals, say, don't forget HPV vaccine today. All right, so it's also good for everyone in the office to understand the mission and understand the importance of adolescent vaccines and HPV vaccine in particular. Just because no one else in your office is enthusiastic, it might just be because they don't understand the importance of it. And so one of the ways that we change behavior is by is with emotion, and so using stories can sometimes influence people more often, and there's some great short stories on Shot by Shot that we encourage folks to watch. This might be a good way to get the rest of your staff engaged in immunizing at every opportunity, especially for HPV vaccine. All right, so I'm going to end there, and I think we're going to take questions. And I just want to remind you that when you think about HPV vaccine, think about it in terms of cancer prevention, and you are the key because you're the person that makes the recommendation that tells mom this is an important vaccine.
Okay, Jill, thank you very much for the presentation. So I'll go ahead and start with the questions now. And just a reminder to everybody else, you can enter in the questions that you have on the right-hand side of your screen in the control panel. It should say questions, and then you would just type what you want and click send. So the first question that I have is, my office still has a number of Gardasil vaccines left. Sorry, I missed what you said about using those for the males first. Why is that?
Sure, that's a great question. So the 9-valent vaccine, the additional 5 types that are 9-valent, primarily are going to provide the most benefit for young women. And that is because those 5 strains are strains that we often see in cervical cancer or cervical dysplasia, high-grade cervical dysplasia specifically. But we don't often see them in the cancers that affect men. So if you've got both and you want to figure out how to parcel it out, I would say give your 9-valent to your female patients and a quadrivalent to your male patients because they're just not going to get the same benefit from 9-valent. But eventually you want to get to having only one vaccine in your office, I'm sure, for HPV. So I did hear a family practice doc say that Merck does take back the expired quadrivalent vaccine, and so if you're close to some expiring, if you have a batch of those, a couple of lots, you could hang tight and keep those until they're ready to return. They won't take them in exchange for 9-valent, but you can do the same thing you do anytime vaccine expires and they take it back.
Okay, and then the next question I have is, for patients who have started the Gardasil vaccine, whether with 1 or 2 shots already, should we finish it with Gardasil 9?
You can do either. Whatever you have in the office is what you should use. If you haven't transitioned yet, you can just use Gardasil. If you have transitioned and Gardasil 9 is what you have, you can use that. I think the important thing is if you do give them Gardasil 9, it doesn't mean they're going to have the full protection of the additional 5 types if they're only receiving 1 shot. Possibly if they're receiving 2, and depending on how far apart they are, we are still waiting on that data to come in about how much protection you get after just 2 doses of Gardasil 9. But for now, just use what you have in the office. But no reason not to give it. I mean, I wouldn't not vaccinate. So if you don't have any regular quadrivalent Gardasil in the office, so just use what you have.
Okay, and then I have, what age is most preferred, 9 or 11, to start the series?
So I think that really comes down on you knowing your patient population. I mean, 11 and 12 is routine, and 11 and 12 is often easy because you can bundle the recommendation. You already have those school-required vaccines that you can bundle it with, and so that works for a lot of parents. If you have a specific patient population or specific patients that possibly you think there's risky behavior going on or soon, maybe it's going to start at age 11 or 12. We've had docs in Baltimore tell us we know our patient population, we start the conversation at 9 and try to vaccinate them at 9. We've also had doctors tell us that they start at 9, they give 1 shot at 9, 1 at 10, and 1 at 11. So various ways to do it. We did have the Georgia AAP meeting, a couple of docs asked questions about they had some patients that were pregnant at 11 or 12, I mean at 12 or 13, and asking if they should start vaccinating sooner. And again, if there's any evidence that the patient's thinking about or will be soon engaging in sexual intercourse, yes. We don't want a risk profile in the opposite direction, though. We don't want to look at a 12-year-old and say, well, I don't think she's going to be having sex anytime soon, so we're not going to vaccinate her. But if you have a 9 or a 10-year-old that you think could be at risk for many different reasons, absolutely go ahead and start vaccination.
Okay, and another one is, I was told that the HPV 9 was not supposed to be given to males over 16.
So currently, Merck has not gotten an indication for males over the age of 16 or 16 and older. That has to do with how much data they've collected. They could have waited. They could have waited to go to FDA with all of the data once they had all the age ranges, but they went ahead and just went for the indication through age 15. However, when ACIP recommended 9-valent HPV vaccine, they harmonized the recommendation. It's not a safety issue. It's truly an issue of just not having enough data to take to the FDA. And so it's a harmonized recommendation. It is off-label. But the ACIP looked at all the available evidence and said there is no reason not to give it to them. So it's absolutely perfectly acceptable to give a 17-year-old 9-valent HPV vaccine.
Okay, and then I have, if we started with Gardasil for females, can we finish with Cervarix?
So in terms of the way that the ACIP recommendation is now written of interchangeability is finish with whatever you have in your office. There aren't a lot of folks that start with Gardasil and then end with Cervarix. It's probably a really small population that happens to. Remember that then you can only say that they're going to get protection against 16 and 18, so the cervical cancer portion. They're not going to get any protection from genital warts, so the type 6 and 11. So that's just one thing to remember.
Okay, and there is, of all the vaccines I've given, HPV is #1 amongst complaints of pain. Some complain radiating down arm into hand. I was told by Merck MD years ago it was the age and nature of hysterical girls, but it is now given to boys, and I find the same complaint. Try as we will to play this off, kids talk, and I believe it is a reason why it's not popular.
Right. So I mean, so first of all, I mean, it's a painful vaccine. It's an adjuvanted vaccine. Adjuvanted vaccines are often more painful. I once had a nurse tell me it was like trying to drive a Mack truck through an arm. So we do expect it to cause some pain. In fact, I mean, that is one of the most common side effects. And I do think kids talk. I think that's though where it's important for a clinician and a parent to say, this is about cancer prevention, and chemotherapy for cancer is a lot worse than a shot in the arm. And sometimes that just has to be the perspective. We've had some docs tell us that they have kids that are like, I don't want another shot. And the parents are like, tough luck, you're getting it anyway. And especially that, they pick that one over the others. So yes, the shot hurts a lot of people. We have some patients who say it doesn't hurt at all, and some it really hurts. And so I think it just depends on the actual patient. I don't think it's a girl versus boy thing, although I think I recently read that there's more syncopal incidence actually in males. I mean, I'm not even sure it's significantly, statistically significant, but I mean, it's happening in equal numbers. But it still could be partially about, the syncope is partially about the immature vasovagal system. About the drama, I do think kids kind of spread the drama amongst each other when they talk about it. I think that happens more in older ages, though. Again, vaccine 11 or 12, you're going to get away with a lot more around them not yet sharing that kind of thing with their peers on social media because maybe they're not on that yet. Or also 11 to 12, parents don't feel the need to go into the sexuality conversation with them. It's just another one of those vaccines you need to get.
Okay, and this is kind of a question that it's kind of the same as something else, but just to reiterate again for everyone, has the recommendations for Gardasil 9 been opened up for males 9 to 26, or is it still 9 to 15?
So I'm going to go back to that slide, actually. Let me very quickly scroll there so you can see it. All right, so the recommendation, so it doesn't matter which type of HPV vaccine you have, whether you have bivalent, quadrivalent, or 9-valent, it is all the same. It can be started at age 9, can go up to 26 for girls, 21 for boys, unless they are immunocompromised or a man who has sex with men, they can go up to age 26. All of them should finish the 3-dose series by the time they turn 13. And that's regardless of the vaccine. So the recommendation has been harmonized across all HPV vaccines.
Okay, so it looks like we don't have any additional questions. If anybody, oh wait, just have another one that came in. It says Medscape article from July 2015 states that there are clinical studies. I'm assuming that's referring to Gardasil 9. If not, please clarify. She said
About 2 doses.
that there are clinical studies that there are side effects from the HPV vaccine.
So one of the things, and I'll actually go to this slide so I can show you. Okay, HPV vaccine safety for 9-valent vaccine. So I think what was mentioned in that is that there are more injection site reactions in those who receive 9-valent HPV vaccine than those who received quadrivalent. There were even more injection site reactions in those who received both. And so there was actually a study where people received the complete series of Gardasil vaccine and then received a complete series of Gardasil 9, and they had many more injection site reactions. I mean, you're getting more of the thing that's creating the immune response, and so the injection site reactions are higher. It's a lot of adjuvant. There's twice as much adjuvant in Gardasil 9 than there is in quadrivalent.
She said 2 syndromes, CRPS affecting limbs and POTA.
Yeah, and POTS and CRIPS and POTS. So so there is a study going on to look at that. Like I said before, this is a vaccine that has been scrutinized tremendously and for good reason, because now we're able to say we have a tremendous amount of safety data. CDC, those are things that actually have been looked at using the vaccine safety data link, and they have not seen evidence of that. But there's always going to be ongoing studies about various vaccine safety and health issues. And so don't let the studies be concerning. And sometimes the studies are they're smaller. And so one of the nice things about the Vaccine Safety Data Link project is it has massive, massive numbers that they're looking at. And then also we use vaccine safety information from other countries because other countries have done a better job of vaccinating than we have. And so we can use their studies because they're gigantic numbers in comparison to ours.
Okay, and why the difference in age between girls and boys? Is there not enough studies for boys over 21?
So it has to do with cost effectiveness. So the reason that we vaccinate boys in the U.S. has to do with the fact that we weren't seeing great increase or great uptake of HPV vaccine in girls initially. In fact, as our HPV vaccination rates increase in girls, it makes it less cost effective to vaccinate boys. Now that said, we now have indications for things like anal cancer for boys. We also know that if someone isn't infected with, say, HPV-16, then it is not there to cause persistent infection that could lead to cancerous changes, say, in the oropharynx. And so I think more and more we're going to see young men who are interested in getting the vaccine, or parents are interested in that for that reason. Up to age 21 has to do with the cost effectiveness. So when ACIP looks at cost effectiveness studies, it's looking at it for public health sake. And by that age, by age 26, most girls have been infected with HPV, and by age 21, most males at that age. And so that's where the cost effectiveness studies played a role. Now that said, any young man, 22 to 26, can get HPV vaccine. It is I think we used to call them permissive recommendations, and I'm not sure what they're calling them now, but there's no reason why they can't get it. In fact, as long as a physician says this child is indicated for the vaccine, they don't have to state why, and then it has to be covered. The payer has to cover it.
Okay, and if your daughter has had the series of quadrivalent, should they have a booster of 9?
So the ACIP has not recommended booster doses for those who received a full series of quadrivalent vaccine, and they're not issuing any recommendations around that. I do know some prominent physicians that have said, I plan to have my child vaccinated with Gardasil 9, get all 3 shots, so it's definitely happening, but at this time ACIP has not recommended that.
Okay.
And I will say that the majority of cancers are caused by 16, and that is the type that most people are likely to get as well. So they're still protected, which is what's important.
Okay, and so this is going to be the last question. It's also the last question I have, but also because we're running out of time. And there was an article that a doctor read that mentions that Gardasil destroys girls' ovaries and is one of the side effects of the vaccine.
Yeah, so there have been studies that have looked at that. So when I mentioned before that there's no evidence that HPV vaccine causes problems with fertility, ovarian failure was one of the things that was looked at, and there is no evidence to support that HPV vaccine causes ovarian failure. The rate of ovarian failure in the non-vaccinated population and the vaccinated population is exactly the same. So no reason to think that HPV vaccine has anything to do with that, and that's what the studies have shown. There are definitely some researchers in different areas that have published information about HPV vaccine safety that has not been replicated. And so, I mean, I would look to CDC, the Institute of Medicine, the Vaccine Safety Data Link, because the numbers are just so big. It's really fantastic data to rely on.
Okay, thank you so much, Jill. So that about concludes our webinar for today, and I just wanted to thank everyone for joining us this afternoon. Shortly after this, probably before the end of business day or early tomorrow morning, everyone will receive an email with a link to the recording of today's webinar, as well as a PDF of the PowerPoint slides. Rush University will email everyone with instructions on how to receive their continuing education credits within about a week or 7 business days. Once again, thank you to everyone for joining us on today's webinar, and I hope that you all have a great afternoon. Thank you again, Jill.
Thank you.
Okay, bye.
Bye.